about the USMLE practice poll question that are regarding immunology. First question is, a 19-year-old man comes to the office due to eye pain and blurry vision in both eyes for the last several days. He sustained an open globe injury to the right eye 3 months ago after being struck during an altercation and was treated with surgical repair and prophylactic antibiotics. The left eye was unaffected. At the patient's last follow-up appointment, the visual acuity in the right eye had improved from 20 to 20/80. He is otherwise healthy. The temperature is 37. An examination is unremarkable apart from bilateral conjunctival injection and decreased visual acuity in both eyes. Analysis of vitreous samples from both eyes demonstrate multinucleated giant cells. Which of the following mechanism is the most likely causing this patient current manifestation? The thing is that in this, the patient having visual acuity in the right eye, this injury was in right eye. But they are asking, after view, there will be bilateral conjunctival injection decrease the visual acuity of both eyes. Last time the injury was only the right eye, but now there is a decrease in visual acuity in the both eyes. What will be the mechanism? Granulomatous response, mixed inflammatory neutrophilic T-cell response, or type 4 hypersensitivity. Actually, this patient with a traumatic injury to the right eye had developed granulomatous inflammation of both the injured and non-injured eye. That condition known as sympathetic. That condition known as sympathetic ophthalmia, in which there is inflammation in the both eye, injured and not injured. This occurs when there is a robust in the T-cell response to previously scattered antigen in the eye and an area that displays the immune privilege. If you guys remember the topic of immune privilege that was mentioned in immunology, there is some organ which there is an immune privilege, there is a less recognition of antigens as a foreign to the immune system. That organs are eye, nervous system, central nervous system, fetus, placenta, testes. These organs are immune privileged organs. So certain anatomic sites have inherent immune privilege in which inflammation is inhibited to limit consequent organ dysfunction. The self-antigens located in the site with immune privilege can be recognized by T cells that escape the negative selection of the thymus. Therefore, if these antigens are released into the lymphatic system through trauma, the T cell may recognize these antigens as a foreign and mount a response that can occur in both the injured eye and contralateral eye. So, due to immune and privilege, this is happening. And because of this potential sight-threatening condition, if an eye is severely injured with no prognosis of recovery vision, it is surgically removed. You have to remove one eye to prevent the abandon in uninjured eye. If you did not remove, automatically the uninjured eye also become effective. So our right answer is T-cell response to previously scattered antigens. Understand? Now we are moving to our next question. A 8-year-old girl is brought to the office by her mother due to chronic pruritus affecting her arms. What's her age? 8-year-old girl. The mother states that the patient is always scratching herself. She scratches through the night, affecting her ability to sleep. Her sister has similar but less severe symptoms. The patient also had intermittent asthma. The rash is shown in the exhibit. The first-line therapy for this patient condition may work for which of following mechanism of action. First of all, this is the image that is shown in the question. Okay, this patient had a pruritic lymphocyte plaques on the bilateral antecubital fossa. Atopic dermatitis is an inflammatory condition that caused by the genetically mediated epidermal barrier dysfunction and immune dysregulation favoring T-helper-2 to skew the response. The patient typically have a family history and a comorbid atopic condition like asthma, allergic rhinitis, as in this patient having already they mentioned. So the first line therapy in that patient is topical corticosteroids. The corticosteroids go and bind to cytoplasmic receptors and translocate to a nucleus where they act primarily by inhibiting the transcription of the gene, encoding inflammatory mediators, and do some specific mechanism that includes in the diagram. If you guys focus, this is a cell, mast cell. This is a gene nucleus where there are gene. The gene transcription going to be inhibited, going to stop by glucocorticoids. To do it, there will be decrease in local tissue production of pro-inflammatory prostaglandins and leukotrienes through the inhibition of phospholipase A2. If you guys focus, if you stop the gene transcription, there will be inhibition of phospholipase. If it will be inhibited, then there will be no production of arachidonic acids. To do it, there will be decrease in leukotriene, there will be decrease in prostaglandins. And due to it, there is decrease in synthesis of pro-inflammatory cytokines like interleukin 4, interleukin 13. And the corticosteroids also increase the production of anti-inflammatory substance like interleukin 10, etc. Okay. So what will be our right answer? First, they are asking us what will the first line therapy for this patient. For the atopic dermatitis, we having first line therapy, topical corticosteroids. Now we have to give them mechanism. The mechanism is inhibition of phospholipase A2 activity in cell membrane. Due to it, there will be decrease in production of pro-inflammatory cytokines or prostaglandin or leukocytes. Now we have moved to our next question. The next question is, a 57-year-old man with suspected bacterial pneumonia is admitted to the hospital and given ceftriaxone and azithromycin for treatment. Soon after the first dose of ceftriaxone, he complains of difficulty in breathing, abdominal cramps, and lightheadedness. His current blood pressure is 70 or 50, while his heart rate is 120. It's a tachycardia and needs a hypertension. The physical examination reveals a diffuse macular papular rash. Which of the following drugs should be administered next to this patient? First, we have to diagnose the disease. What is happening here? Guys, he's a normal. He comes with a pneumonia. But after we are giving the dose of antibiotic, he gave the symptoms of within while he is presenting with a symptom of difficulty in breathing, dyspnea, hypotension, tachycardia soon after the administration of beta-lactam antibiotics, and it is suggestive of anaphylactic shock. And you guys know in anaphylactic shock, which of the following should be Neutrophil? The first line drug we are going to administer is epinephrine. The answer is epinephrine. What will be the route? It's also recommended in the question. That is the IM, intramuscular. We are giving intramuscular epinephrine. The epinephrine is a drug of choice for the treatment of anaphylactic shock due to the ability to reverse all of the pathophysiological mechanisms of anaphylaxis. Stimulation of alpha-1 receptors counteracts the vasodilation of cutaneous and vice versa vasculitis, increase the blood pressure, and epinephrine mediates increase in cardiac contractility by the beta-1 effect, and cardiac output also increase the blood pressure and improve the peripheral perfusion. So, epinephrine-induced stimulation of beta-2 receptors results in bronchodilation, making it more a popular choice for treatment of severe asthmatic reactions. Understand? Now we are moving to our next question. Our next question is, a 72-year-old woman is brought to emergency department for a nursing faculty due to fever, chills, hypertension. The patient has history of diabetic mellitus, ischemic stroke, and neurogenic bladder. She had indwelling urinary catheter. Temperature is 38.8 degrees Celsius. The blood pressure is 80/40. He having a fever. Okay. 1840 hypertension. The pulse is 130. Okay. The patient is lethargic and disoriented. Her extremities are warm and her breathing is rapid. Lungs are clear on auscultation. There is no heart murmurs. There is a left costovertebral angioedema and the urine in her catheter appears cloudy. Infection. Her leukocyte count is elevated with left shaft and urine analysis show pyuria and bacteria. Which of the following chemical mediator is the most responsible for this patient condition? When we observed in setting of infection, the combination of hypertension, tachycardia, tachypnea, and the markedly elevated or decreased body temperature is suggested of septic shock. The early sepsis is characterized by peripheral vasodilation and compensatory increase in cardiac output in the warm extremities. Numerous cytokines are released in septic, releasing in widespread the systematic inflammation. The one of the most important mediator of sepsis is tumor necrosis factor alpha. It is an acute phase cytokine produced by activated macrophages. And it stimulates the systemic inflammation by the recruitment of additional leukocytes like neutrophil and macrophages and increase the pro-inflammatory cytokine production. Other cytokines are responsible for increasing systemic inflammatory response in sepsis, including interleukin-1, responsible for fever, and interleukin-6 also. Okay? If we talk about other cytokines like interleukin-3, it is produced by activated T cells. It is going to produce by activated T cells and stimulate the growth and differentiation of stem cells in bone marrow. If we talk about the interleukin-4, it is also cytokine produced by T helper cell to and stimulate the growth of B cells and increase the number of helper 2 cells at the site of inflammation. Then we have interleukin-10. The interleukin-10 is an anti-inflammatory. It is anti-inflammatory cytokine and it's produced by macrophages. Macrophages and T helper cell. The interleukin-10 limits the production of pro-inflammatory cytokines. You guys already know what are the pro-inflammatory cytokines? Pro-inflammatory inflammatory cytokines. What are they? Are interleukin 2, 3, tumor necrosis factor, alpha, and interferon gamma. It is there or more also there. Next, I have leukotriene B4. They are most responsible for the chemotaxis of neutrophil and other leukocytes, and it is a metabolite of arachidonic acids. And if we talk about the transforming growth factor beta, then it is released by macrophages and has anti-inflammatory role in sepsis, including the suppressing the release of interleukin 1 and tumor necrosis factor alpha and inhibiting the lymphocyte proliferation. Like all about the septic shock. Now we move to our next question. Our next question is, at 37, you're meant to come emergency department because of increasing pain and tenderness in right forearm. During a bar about 6 years earlier, he sustained a 4 centimeter laceration to the skin and subcutaneous tissue of his forearm. The treatment at the time of entry including cleansing and dressing of wound. The physical examination shows erythema surrounding the wound site and expression of yellow pus when pressure is applied adjacent to the wound. Which of the following molecules is likely responsible for causing accumulation of pus over this patient wound? Guys, first of all, we have to answer what the things are going to form the pus. The pus consists of thin protein-rich fluid. Those are liquid purus, and they are having the dead leukocytes, primarily neutrophils. So during infection, the macrophages and surrounding endothelial cell release some cytokines such as interleukin 8 that triggers a neutrophil to enter the site of infection via chemotaxis. The interleukin 8 also induced phagocytosis in neutrophil when they have arrived. Understand? So first, which thing is responsible for the accumulation of pus, formation of pus is neutrophils. And neutrophil is going to do chemotaxis by interleukin 8. You guys would also seeing this option. This is C4, not B4. The B4, the leukotriene B4 is responsible for chemotaxis of leukocytes. Understand? If we talk about the bradykinin, it is a component of kinase system which causes vasodilation, increase vascular permeability, and stimulate the non-vascular response muscle contraction and mediates pain. And if you talk about other complements, the C3 is a component of complement system, and like 4A, 5A are inflammatory anaphylactic toxin that triggers the histamine release from the mast cells. In that, the C5A is responsible for the chemotaxis of neutrophils. Okay? Now we are moving to our next question. The next question is, a 12-year-old girl is being evaluated for the recurrent episodes of self-limited abdominal pain and the nausea lasting several days. She was also recently hospitalized of an episode of difficulty breathing. The patient has no significant past medical history, but her mother has a history of attacks of severe abdominal pain and diarrhea. The physical examination is unremarkable. The laboratory evaluation reveals decreased serum complement C4 and C1 esterase inhibitors level. Which of the following drug is contraindicated in this patient? First, this patient with acute pruritic rash and a history of environmental allergies has a typical presentation of hives, urticaria. The hives are triggered in the most cases by the IgE-dependent mast cell degeneration, and histamines are one of the primary mediating this type of allergic reaction. Like antihistamines are the preferred treatment in the most cases. Serum levels of C1 esterase inhibitors and its substrate like C4 are diagnostic of hereditary angioedema. It is an inheriting autosomal dominant condition that causes the episode of painless, non-pitting, well-symptomatic edema. The face, neck, lips, and the tongue are most commonly affected, but internal organs may also be involved. The angioedema affecting the tracheobronchial that can cause respiratory obstructions and is potentially fatal. Angioedema of the gastrointestinal tract manifests in abdominal pain, vomiting, and diarrhea. Normally, the C1 esterase inhibitors suppress the activation of C1 complement components, and therefore the rest of plastic complement pathway is also inactivates the kallikrein, which is catalyze the conversion of kininogen to into bradykinin. And in hereditary angioedema, the low C1 esterase inhibitor activate lead to an increase in active kallikrein and bradykinin level. Because this C1 esterase is absent, so there will be activation of this kallikrein. So what is function? It is going to convert kininogen into bradykinin, to automatically no one who will go and inactivate kallikrein. So there will be increase in bradykinin. The bradykinin along with C3A and C5A, they're going to mediate angioedema by increasing the vasodilation and vascular permeability. Already there is edema, already there is angioedema, but when they will increase in bradykinin, they will more increase in vasodilation and increase in edema. Due to increasing vascular permeability, the angioedema may also occur as a side effect of angiotensin converting enzyme inhibitor. So in that patient, the most contraindicated drug is AC inhibitors. And if you guys found any AC inhibitor in that options, yes. Option A, the captopril. Because AC normally catalyzes the conversion of angiotensin 1 into angiotensin 2, the AC also converts bradykinin into inactive metabolites. The AC inhibitors can therefore lead to bradykinin accumulation. Again, I will give you one elaboration how the bradykinin level will be increased by AC inhibitors. Firstly, there was kininogen that's going to convert in bradykinin by one enzyme, that is kallikrein. And this is going to inhibit by C1 esterase. The C1 esterase is known there, so it is active and happy and doing more work and doing more conversion of bradykinin. Now you are going to take AC inhibitors. Okay. What was the work of AC androgen converting enzyme? They convert the bradykinin into inactive metabolite. It happens in the presence of angiotensin converting enzyme. But when you guys come and inhibit angiotensin converting enzyme, then they will automatically increase in bradykinin. First, due to this disease, absence of C1 esterase, already there is increase in bradykinin. But when you guys are taking ACE inhibitor, they will more increase in presencanin, and it will be very vulnerable. Edema and patient can be lead to death. So our next question is, a 58-year-old woman comes to the office for the health checkup and starting volunteer work at hospital. She has a history of hypothyroidism and may take levothyroxine. The patient feels well and review of system is negative. She does not use tobacco, alcohol, or illicit drugs. Her examination findings are unremarkable. During a laboratory test, her blood cells are incubated with mycobacterial antigens compared to control. A large amount of interferon-gamma is detected in her blood sample, which the following serotypes is most directly responsible for these findings. Guys, now what they are asking? They are asking, in this patient, they are increasing the amount of interferon-gamma. It's not a conceptual question, just a thing to remember. Did you guys know which of the following is going to produce interferon-gamma? The interferon-gamma is going to produce by T lymphocytes. The interferon-gamma activates macrophages that increase the major histocompatibility complex of expression and promote T helper 1 lymphocyte differentiation. It produced primarily by the activated T lymphocytes and natural killer cells also. And it is critical for immunity against a viral and intracellular bacterial infection. The interferon-gamma release ACEs test for latent tuberculosis infection by mirroring the response of T lymphocyte when exposed to the antigen unique to Mycobacterium tuberculosis, and similar to tuberculin skin test, the IgRA measures immunity. Understand? Now we are moving to our next question. Our next question is, an 11-year-old girl brought to the office for a health maintenance visit. She feels well and has no chronic medical condition. As part of routine care, the patient receives the first dose of the quadrivalent meningococcal conjugate vaccine and 9-valent human papilloma virus vaccine. 5 minutes later, while being escorted to the waiting area, the patient appears pale and reports feeling dizzy. She immediately rose consciousness, but a fall is prevented by the healthcare provider. Blood pressure is 70 and 14 pulse 46. On physical examination, the patient had a normal lung and heart sound. There is no rash for to the following most likely cause of these patients and co. Okay. When you guys start reading this question, oh my god, it is a reaction. It's an anaphylactic reaction because it is happening within minutes, in which there is a decrease in the blood pressure, feeling dizzy, unconscious, vasovagal. It having bradycardia. In anaphylactic reaction, we are having tachycardia. And secondly, the patient is a normal lung, but in anaphylactic reaction, there is a wheezing. There is no rash, but in anaphylactic reaction, there is a rash on the skin. So, it is the case of not IgE-mediated hypersensitivity reaction to vaccine allergy. It is the case of stress-induced cardioinhibitory and vasodepressor response. How? Let me elaborate. Actually, this patient most likely experienced Vasovagal syncope, which involves a pain-induced or emotional distress that induces a cardioinhibitory and vasodepressor response. When the vaccine starts administration, the non-precipitant of the vasovagal syncope, especially in adolescents, because syncope-related falls can lead to serious injury like scalp fractures, intracranial hemorrhages. The patient should be closely monitored for 15 minutes following vaccine administration. So, in adults, the vaccine administration is also one cause of Vasovagal syndrome in adults. So, patients with a Vasovagal syndrome typically experience a prodrome like pallor, nausea, and diaphoresis prior to losing consciousness. The mechanism not well understood, but the trigger in combination with a state of orthostatic stress like upright position or dehydration believed to signal to the CNS to decrease the sympathetic activity and increase the parasympathetic tone, overriding the normal baroreceptor response. And this leads to bradycardia and induce the left ventricular contractility and decrease the peripheral vascular resistance, resulting in hypotension, decrease cerebral perfusion, and ultimately syncope. The symptoms rapidly resolve within 1 to 2 minutes. It spontaneously resolved within 1 or 2 minutes. So it is a very confusing topic. After the vaccination, related hypotension and syncope. So we will relate how it is triggered. The vasovagal syncope are going to trigger by the pain and emotional distress. The patients are so afraid and having fear of injection. And anaphylaxis is just vaccine antigen that going to cause allergy. Its mechanism is vacuole-mediated cardioinhibitory and vasodepressor response. Okay, due to decreasing the sympathetic and increasing the parasympathetic activity. In anaphylaxis, there is an IgE mediated response leading to widespread release of inflammatory mediators. If we talk about the clinical presentation, there is a prodrome like pallor, nausea, and diaphoresis, hypotension with bradycardia and rapid respiration. If we talk about anaphylaxis, there is a rushes, heaves, hypotension with tachycardia. There is hypotension with bradycardia. They are having the wheezing, they don't have phase and progressive symptoms. For the management, we are giving immediate epinephrine in anaphylaxis reaction, intramuscular, and for stress-induced vasovagal syncope, we have to make the patient lying supine with legs elevated and it will be spontaneously resolved within 1 to 2 minutes. Now we are moving to our next question. Our next question is about a 5-year-old boy. The 5-year-old boy is undergoing a partial hepatotomy to treat a poorly draining liver abscess. He has history of recurrent skin abscesses. Cultures from his liver abscesses are showing Staphylococcus aureus, which is sensitive to current antibiotic regimen. But the abscess had failed to improve. And secondly, if we make the genetic analysis, it reveals inactivating mutation affecting a neutrophil oxidase enzyme. This patient most likely having the disease infection which of following organism. First, we make the diagnosis. The patient with mutation in the neutrophil oxidase enzyme has chronic granulomatous disease. It is CGD, a condition that results in recurrent bacterial and fungal infection due to impaired intracellular killing by phagocytes. In this, the highest risk of the infection is by which organisms? Catalase positive. Do you know in these organisms which one is a catalase positive? Yes, the catalase positive is Picardia cepacia. This one is catalase positive. If we talk about other organisms, we are also having a table. Here is CGT. First, we talk about the pathogenesis is X-linked recessive mutation of N NADPH oxidase. It may then impair respiratory burst and decrease the reactive oxygen species due to a decrease in hydrogen peroxide and make an inhibition of phagocytic intracellular grinding. So, most probably this species is the most prone to catalase positive organism in bacteria that is Staphylococcus aureus, Bacteroidetia, and Ceratria. And Nocardia also in fungi and fungal there is Aspergillus. If we took away clinical features, say the recurrent infections are lung, skin, liver, and lymph nodes with the diffuse granuloma formation. For the diagnosis, we make the measurement of neutrophil superoxide production by the DHL4 cytometry and NBT testing that is the dihydroamine and tetrazoine in which it will not turn into blue color. Understand? This is all about for today's immunology and USMLE practice part. See you in next Sunday.